safely assist a resident during mealtime and identify whether the resident needs further follow-up or assistance from me, the speech therapist, or the physician. And so when we're talking about the importance of eating, proper nutrition supports overall health and well-being. It's a great time to socialize. It's one of the activities our residents can still participate in, be with their peers. It's a ritual, it's a comforting routine, and it's one thing they can still be as independent as possible and participate in. The National Institute of Health estimates that 45% of people with dementia in institutionalized buildings have difficulty chewing and swallowing. So that's a pretty significant amount of our population. The risks of unsafe eating. Dysphagia, that's the word I'm always talking about here. That means the impairment or disorder of eating and swallowing. It's referred to as dysphagia. So difficulty eating, chewing, swallowing. Penetration is the foreign material that goes above the level of the vocal cords toward your airway. It does not go under your vocal cords. So typically, if something hits our vocal cords, our body produces a cough or a throat clear to get it out of there. Penetration means it stays above the vocal cords, but it's heading down toward the airway. Aspiration is any material, mucus, food, saliva that goes below the vocal cords, which goes directly into the lungs, and that's one way people can get pneumonia. So we're always looking for signs of penetration and aspiration, because this can lead to pneumonia. It can also be related to malnutrition and dehydration if people aren't able to feed themselves safely. Urinary tract infections are common with dehydration, and death is a major concern. Signs that we see during meal times, med pass, water rounds, where we can check for signs of penetration or aspiration, are coughing, drooling, gagging, nasal drainage, nose drip, wet gurgly voice, how you might sound if you're trying to talk underwater, decreased intake, meaning not eating and drinking enough food, and then recurrent upper respiratory infections like pneumonia. Now we're going to talk a little bit about safe eating and what we can do to promote safe eating. At meal times, when taking pills, it's always important to promote these aspects. Head upright and midline, like you're sitting in a chair. Trunk upright and close to the table. Wheelchair legs should be removed if possible, so that the person can get closer to the table and have a better position. Food and utensils should all be in the field of vision and reach, which is 12 to 18 inches for our typical patients. And make sure the resident is alert. That's a big one. Not at all safe to eat, drink, swallow if they're not awake, they're not conscious, they're not participating. So, good ways to promote safe eating. Introduce one food at a time. It can reduce stress, reduce overstimulation. Ensure that the food or consistency and liquid is appropriate per the speech therapist or physician orders. We're talking the thickness of liquids, the consistency. Utilize small portions and small bowls or plates as needed. Cut foods into bite-sized pieces to promote self-feeding and safety, ability to chew. It's easier to chew and swallow smaller amounts. And make sure that whatever personal assistance device or equipment needed is being provided, such as scoop plates, modified silverware, modified cups. So my area of expertise is more so the consistencies, the food and the liquid consistencies, whereas occupational therapy looks at more the adaptive equipment. So we work together to target chewing and swallowing difficulties, and in some cases residents might need occupational therapy or speech therapy or both. So food and liquid consistencies, my area, there are different thicknesses of liquid. Pudding thick, which is very uncommon. It is the thickness of pudding. We typically don't provide that here, as it is very difficult for someone to stay hydrated on pudding thick liquids. Honey thick, we do offer thickness of honey. Our packages typically have yellow on them for Honey Thick, color of a bumblebee, yellow, honey, try to remember it that way. Nectar Thick is similar to tomato juice. It is in between thin or tap water consistency and Honey Thick. And then there's thin liquids, or some call it regular, that comes out of the tap water, coffee, ice cream, Jell-O, sherbet, watermelon, those are all considered thin liquids as well. Food, we have pureed food, should be no lumps, no bumps, smooth, consistent with applesauce, yogurt, pudding, mechanical soft food, and that can vary a little from building to building, but typically moist. Small pieces of meat, vegetables should be fork mashable, easy for the person to eat, easier to chew, good for people with dental issues. Finger food is great for this population. The more finger foods we offer, the better. This can be promoted by cutting the food up for the patients, providing things like French toast sticks and things they can grab and manipulate on their own. Good for people with more fine motor deficits, trouble using utensils as well. And regular, that's anything. That's what you and I eat. Any consistency includes things that are crunchy, hard, chewy, sticky, nuts, potato chips, big pieces of meat. Everything is allowed on this diet. Any questions about that? I know that food liquid consistencies are complicated. Any concerns about what should be on what diet? Yes.
Can you just go over again when you were talking about what's considered a thin liquid when it comes to like ice cream and especially watermelon?
Yeah. So this is where very commonly people get this one mixed up. Thin liquids are considered anything from the tap, your water, your juices, coffee, but also a number of foods that contain liquid. So watermelon is one, it's all water. Citrus things like, if you're having orange slices, that would be something to avoid. Malts, shakes, anything that melts to the liquid of a thin consistency in your mouth before you swallow it is considered a thin liquid. Jell-O is also one of those things. Sure, it looks solid. In your mouth it melts to a thin liquid. It goes down just like you're drinking a glass of water. Other things to avoid, grapes, citrus fruits. Think about if it's mostly liquid, it's a thin liquid. Soups, mixed consistencies such as soup, frothy soup. Those are going to be thin liquids. Now if it's a thickened liquid, such as a chowder or something that remains thick, that would be okay for someone on a thickened liquid diet. Otherwise, the soup needs to be thickened. So frothy soups would be something to avoid. Keep in mind some things that are pureed or separate on the plate might become a thin liquid. You know, I've seen pureed eggs that haven't been appropriately thickened, they sit and they separate, and then there's half liquid, half solid. That would be a thin liquid. Try your best with residents and families to provide education about, they want to bring in a milkshake for their family because they're having trouble swallowing. If they're on thick liquids, that's not appropriate. An alternative would be if they can have a magic cup, a pudding, a yogurt, something like that.
What about the use of straws with thickened liquids?
Sure. Straws can be provided with nectar thick liquids depending on if the person is safe for that, and that should typically be evaluated by the speech therapist. I personally, or I typically put in no straws if that's not appropriate. Keep in mind, a lot of people can have trouble with straws. Straws can also be beneficial. It really depends on a case-to-case basis. You have some residents who can't, grab their cup, so drinking from a straw is easier because of physical demands, and that might be safe for them, whereas another resident might take huge drinks from a straw. Straws move liquid down faster, and it's easier to take those big drinks, and then they can have more difficulty. So for some it might be helpful, for some it might be harmful. It really should be assessed. If you watch someone drink from a straw and you're noticing those signs of penetration or aspiration, it'd be a good thing to get assessed. The physician can also write an order for no straws. We can chart that as well. Any other questions about that? All right, so adaptive equipment is more of an occupational therapy change. We have divider plates, such as this one here. We have scoop plates. This also has the scoop rim on it, or somewhat. We have a visitor. Hello. Are you going to sit for us? Wonderful. We have weighted utensils, good for people with tremors. We have built-up handles, easier to grab, wrist weights, quantity control cups, which I've recently been using for people who are chugging liquids. It can slow them down. Plate guards, bent utensils, universal cups, handle cups, and sipper cups. All right, so how to approach a resident. Sit on the side of the resident that they use to feed themselves. The occupational therapist and I were just doing this the other day, trying to figure out which side the resident used. They couldn't tell us if they were right-handed or left-handed. So you can try, hand them something, see what they go for. Give them a pen, see which hand they want to write their name with, if you're not sure. Engage socially with the resident rather than your peers. Now, I know some residents are a little harder to engage, but it's mealtime, it's a pleasant time. Talk to them about the food. Doesn't it smell great? It looks good. Are you hungry? The more you engage with them, you increase alertness, increase appetite. Residents are just like the rest of us. If you hear positive things, you know, it can make it a more positive experience. Encourage the resident to be as independent as possible and allow the resident to eat at their own pace. We might have some residents who eat quickly, maybe too quickly, maybe serve them at a different time. If someone needs more time, serve them first.